All right, let's dive right into this rapid-fire explainer on surgical metabolism and acid-base homeostasis. We're tackling some incredibly complex physiological concepts today, and we're going to do it through strict, continuous, rapid-fire clinical rounds. So let's get straight to it. Question 24. Which of the following is the source of fatty acids in total parenteral nutrition? Is it A, canola, B, sunflower, C, cod liver, D, olive, or E, mustard? And the correct answer is B, sunflower oil. You see, intravenous lipid emulsions in TPN are primarily derived from soybean or sunflower oil to provide essential linoleic and alpha-linolenic acids. The absolutely crucial point to remember here is that the human body literally lacks the metabolic machinery to synthesize these long-chain fatty acids from non-dietary building blocks. We just can't do it. So, replacing them via TPN is absolutely mandatory to prevent essential fatty acid deficiency. Moving right along to question 25. Which of the following is true regarding crystalloids? A, NaHCO3 via central line. B, normal saline has 154 milliequivalents of sodium and chloride. C, Ringer's lactate has 154 milliequivalents of sodium. D, 5% dextrose is isotonic. Or E, KCl given fast. The correct answer here is B. Normal saline contains exactly 154 milliequivalents of sodium and 154 milliequivalents of chloride per liter. Now, what's really interesting about this composition scaling is the chloride gap. Normal human plasma only has about 98 to 106 milliequivalents of chloride. Because of this massive gap, infusing large volumes of normal saline can directly trigger a hyperchloremic metabolic acidosis. It's a classic pitfall. Let's keep this rhythm alive with question 26. Which of the following is true regarding colloids? A, superior to crystalloids? B, given in the first 12 hours in burns? C, cost-effective? D, retain intravascular volume initially? Or E, used as maintenance fluids? I want you to really weigh those physiological pros and cons carefully here. The correct choice is D. Colloids contain high molecular weight particles that retain and expand intravascular volume initially by exerting oncotic pressure. But wait, why not option B? Well, you must absolutely avoid colloids in the first 24 hours of burn resuscitation. Early on, the systemic inflammatory response causes widespread capillary leaks. Infusing colloids during this crucial window just forces large proteins into interstitial spaces, dragging fluid with them and severely worsening tissue edema. Next up, question 27. Moderate decrease in basal metabolic rate occurs in A, adrenalectomy, B, major burns, C, major fractures, D, vagotomy, or E, major trauma. Think deeply about the endocrine control over your systemic energy expenditure for this one. The answer is A, adrenalectomy. By removing the adrenals, you completely lose your endogenous cortisol and catecholamines, which are your primary counter-regulatory stress hormones. Losing them induces a moderate BMR drop. The other options, things like burns, trauma, and fractures, those represent severe hypermetabolic stress states, which massively upregulate the BMR instead. Question 28. Which of the following represents the metabolic response to trauma or injury? A, retention of sodium. B, retention of potassium. C, hyperthermia. D, hyperchloremia. Or E, decreased BMR. Keep those renal and endocrine reflexes top of mind. The correct answer is A, retention of sodium. Let's enthusiastically break down this cascade because it's fascinating. Severe injury activates the renin-angiotensin-aldosterone system. Aldosterone acts directly on the distal convoluted tubules to drive sodium reabsorption, brilliantly preserving blood volume. To pull this off, potassium has to be excreted. But here's the big exam pearl. Tissue damage releases massive amounts of intracellular potassium into the bloodstream. This creates a really serious acute risk for hyperkalemia immediately following tissue injury, completely despite that renal excretion. Question 29. The characteristic changes following a major operation or injury includes all of the following except A, hypermetabolism, B, fever, C, increased O2 consumption, D, hyperphagia and weight gain, or E, negative nitrogen balance. Make sure you spot the physiological outlier here. And that outlier is D. Patients absolutely do not experience hyperphagia and weight gain. In fact, major trauma creates an intensely catabolic state causing rapid weight loss. Accelerated skeletal muscle proteolysis shoots way up, throwing the patient into a severe negative nitrogen balance. And a quick clinical warning, aggressively force-feeding these highly stressed patients with high-calorie dextrose doesn't reverse the muscle wasting. It actually just causes severe hyperglycemia and hepatic steatosis. Let's propel right into cellular pathways. Question 30. Hepatic glycogenolysis is mediated by which of the following hormones? A. Cortisol. B. Growth hormone. C. Antidiuretic hormone. D. Glucagon and epinephrine. Or E. Epinephrine alone. Which of these are stepping up to prevent hypoglycemia during extreme acute fasting? The answer is D. Glucagon and epinephrine. And this brilliantly illustrates a classic step-by-step cellular pathway. Step 1. Glucagon and epinephrine are released during stress. Step 2. They activate the CAMP signaling cascade. Step 3. This activates the rate-limiting enzyme glycogen phosphorylase, initiating rapid hepatic glycogenolysis. But here is the critical pearl you have to remember. Human hepatic glycogen stores are highly limited. They completely vanish within just 48 hours of continuous fasting. All right, shifting gears into our acid-base segment. We have a serious scenario here. Question 31. A patient presents with severe hematemesis. ABG shows a pH of 7.2 and decreased HCO3-. What is the diagnosis? A. Resp-acidosis. B. Metacidosis. C. Metacidosis plus resp-alkalosis. D. Resp-alkalosis. Or E. Metalkalosis. The correct answer is B. Metabolic acidosis. The systemic pH is 7.20, which confirms an absolute acidemia. The concurrent drop in serum bicarbonate confirms that the primary driver is a metabolic acidosis. In a severe bleeding scenario like hematemesis, systemic hyperperfusion creates lactic acid from hemorrhagic shock, pulling down both your pH and your bicarbonate in tandem. Let's look at a post-operative case. Question 32. An emergency upper midline laparotomy patient. What is the expected ABG? A. Low pH, high PCO2. B. Low pH, normal PCO2. C. Marked low pH, markedly high PCO2. D. High pH, low PCO2. Or E. High pH, high PCO2. Focus right in on the respiratory consequences of upper abdominal incisional pain. Let's immediately stack the next question to keep our momentum high. Question 33. A 64-year-old emphysema patient with confusion and agitation. pH is 723, PaO2 is 42, and PaCO2 is 75. Best initial therapy. A. High-flow O2. B. Bicarbonate. C. Dexamethasone. D. Ativan. Or E. Intubate. How do we manage this acute hypercapnic encephalopathy? So, connecting both of these. For question 32, the answer is A. Upper laparotomy pain causes diaphragmatic splinting and shallow breathing. This hypoventilation traps CO2, causing a primary respiratory acidosis. For question 33, the answer is E. The patient is in type 2 hypercapnic respiratory failure with acute neurological symptoms. You must intubate immediately to secure the airway and clear that retained CO2. And a huge warning here, beware the dangerous oxygen trap in emphysema. Giving high-flow O2 without a secured airway can rapidly remove their hypoxic drive to breathe, which can literally lead to respiratory arrest. Keeping the pace fast. Question 34. What is the most common acid-base disorder in chronic liver disease, like cirrhosis? A. Metaacidosis. B. Metaalkalosis. C. Respiration acidosis. D. Respiration alkalosis. Or E. Mixed disorder. Can you identify the paradoxical acid-base shift caused by hepatic failure? And our final pure electrolyte question, question 35. The most common electrolyte abnormality associated with metabolic alkalosis is A. Hypokalemia, B. Hypocalcemia, C. Hyperkalemia, D. Hypernatremia, or E. Hyponatremia. I want you to really visualize your transcellular ion exchange mechanisms right now. Okay, let's dive into this. For question 34, the answer is D, hepatic toxins, like ammonia, bypass failing liver clearance and act as chemical irritants, literally hyperstimulating the medullary respiratory center. This constant hyperventilation washes out CO2, causing a respiratory alkalosis. For question 35, the answer is A, hypokalemia. During an alkalosis, your body desperately tries to lower the blood pH by shifting hydrogen ions out of cells. But to maintain electrical neutrality across the membrane, it has to pull potassium out of the bloodstream and into the cells. This massive shift triggers systemic hypokalemia. Here is our final question. Question 36. A post-AAA repair ICU patient shows a low pH, low HCO3, acidic urine, and is hyperventilating. What is the underlying cause? A. Respacidosis. B. Metacidosis. C. Sepsis. D. Resbalcalosis. Or E. Metalkalosis. We are brilliantly combining surgical ischemia with renal compensation mechanics here. The correct answer is B. Metabolic acidosis. This is primarily driven by postoperative acute kidney injury from transient renal ischemia during aortic clamping. The hyperventilation you're seeing is simply the body's rapid respiratory compensation attempt. So let's summarize our high-yield pearls from today. Normal saline causes hyperchloremia, alkalosis equals hypokalemia, and respiratory acidosis equals retained CO2. Knowing these facts is great, absolutely, but predicting these exact transcellular shifts before they happen is what truly dictates survival in the ICU. So the real question is, will you be ready to anticipate the crash before the numbers even hit the monitor?